Good morning. I think we can do better than that. It's Friday. We're going into the weekend. Good morning. All right. I was telling my staff last week, it doesn't cost a thing to smile. We don't have to pay to laugh, and we should thank God for that. All right, so I want to give you a bit of an overview of what we have been working on at the Texas Health and Human Services Commission. And I would be remiss if I did not name other partners that have been very much involved in this work with us at the Texas Juvenile Justice Department, the Department of Family and Protective Services, the Children's Commission, and a host of other stakeholders. I'm gonna start with a question, a show of hands. How many of you are serving children? Yeah, okay. How many of you serve adults with children? Yeah. According to the US Census Bureau, 1 of every 10 people under the age of 18 lives in Texas. 1 of every 10 people under the age of 18 lives in Texas. In 2022, 24% of the 30 million people in Texas were children under the age of 18. 7.2 million children in 2022 lived in Texas. Conversely, in 2022, 10.9% of Texas children under the age of 19 years old did not have health insurance coverage. Say it again, 10.9% of Texas children under the age of 19, this was in 2022, did not have health insurance coverage. For those that were insured, the majority of those that were insured were covered under private employer-based insurance. I'm gonna pose a question to you. Can you tell me the next highest level of insurance? What was that for Texas children? Medicaid. Yes, that's right. So, 2 highest forms of insurance, private employer-based insurance, next to that, Medicaid. So last session, oh God, now y'all, I'm 40, but I tell people I'm the world's worst millennial, have no expectations for that. Okay. So last legislative session, the Texas legislature directed the Texas Health and Human Services Commission in our support of implementation of the statewide Behavioral Health Coordinating Council to develop a subcommittee that is charged with developing a children's behavioral health strategic plan. And they said to us in this plan that we have to include a description of who is providing what services to children, what strategies are needed to identify and address gaps in care, a discussion of workforce shortages, information on funding and reimbursement, and children-specific data and expenditure information. So we developed that subcommittee. I won't go through this list, it's up on your screen, but we had representation from providers who are delivering outpatient services, inpatient services. We had representation from policy-focused organizations. We had individuals with lived experience, youth, as well as parents, and other kinds of organizations that we brought to the table to help us to identify what are the needs of these children. And I can tell you, when we were looking at some of the research and data on children, it blew my mind. It was mind-blowing. And I worked for the Texas Health and Human Services Commission for 11 years. I don't retire until 2043. I was telling Mike Maples, so I'm sure I will have lots of other surprises in store for me in this span of time. But this was data that was unfamiliar to me because much of my work has been adult-focused. So to really dig in and look at the needs of children from really a holistic perspective. What does it look like in education? What does it look like in behavioral health? What does that look like from a housing perspective? What does it look like from a parental employment perspective? There were some stats that you'll see when you look at this plan that were really mind-blowing. So in the development of this plan, what we wanted to do is use a framework for this plan that we believe really underscores what is needed in helping kids and families access care. And so we decided to use a system of care philosophy and model. System of care is a philosophy that is called by a name that is probably very familiar to you. We're basically talking about bringing communities together, multi-sectoral partnerships, like we see with the Judicial Commission and the Children's Commission, to come together and provide governance structure over local behavioral health services. But we want those services to be driven by truly what children and families believe that they need. I have twins, they are 4 years old. I would hate for a professional to tell me what they believe Madison and Mackenzie needs, right? Because I'm telling you, you don't know what Madison and Mackenzie need like Jason and Courtney know what Madison and Mackenzie need. So we really believe that families, children and families should be at the center of the planning. This is a 5-year plan. It'll span 2025 through 2029. We'll refresh it every 2 years. And we really wanted to focus on that birth through 17 population. There were people on the subcommittee that said, well, what about going up to age 22? What about going up to age 26? Because if you have children yourself or you're very familiar with providing services to children, you know that brain development takes a while, and really gaining independence takes a while. I'm pretty sure some of you still have adult children living with you, maybe. I don't know. I don't want that to be my story, but I hear it is a story. So we decided that we wanted to focus on that birth through 17 year population, because generally, if you're talking about children accessing care, that is the population that we're talking about. When you get 18, right, you're likely going to receive care in the adult focus system. So how did we collect information to inform our plan? Of course, we did literature reviews, and we had presentation series that were very fruitful. We held focus groups with youth and family members, Department of Family and Protective Services and the Texas Juvenile Justice Department and Texas Education Agency and the Health and Human Services Commission came together to engage in a national children's behavioral health policy lab, where we got some technical assistance from health management associates and other organizations. We leveraged our partners at Texas A&M University, because they also, during the last legislative session, were provided funding to do a study on access to mental health services for children and adolescents, but with a focus on what do we need by way of inpatient capacity. But of course, you know, you can't talk about what we need by way of inpatient capacity without building out what we need in a community environment. And then we also consulted with the Hogg Foundation for Mental Health and Meadows Mental Health Policy Institute. So what did we find by way of gaps? And I think what we found by way of gaps is probably not going to be a surprise to many of you. What we found, I'm going to start with rates for reimbursement for behavioral health services, because what we heard from people who actually provide behavioral health services is that the acuity of the children that they are serving now is unlike the acuity of the children that they were serving even 10 years ago. What we heard is that you now have children with really complex trauma. You see sexual abuse history, physical abuse history, bullying, right, hyperarousal, et cetera. And so they said, really, the acuity of the children is higher, and the treatment environments that we have available to us really aren't suitable to meet the holistic needs of these children in a way that is safe not just for the children, but is also safe to staff. And they said, and you're paying us a rate of reimbursement for these services that does not reflect the acuity of the children being served. This feeds into workforce because when we were looking at workforce data for psychiatrists, psychologists, counselors, and social workers, the Behavioral Health Executive Council, who licensed many of these professionals, did a survey and asked them, how many of you all take insurance? Any guess on the percentage of people who said, we don't take any form of insurance? 80%, it wasn't 80%, it was a bit over 60%. But 60% of those professional surveys said they don't take any form of insurance because the rates of reimbursement were too low, A, and they also said they did not want to have frequent communication with insurance companies about not reimbursing them for an evidence-based practice that they knew was going to help the child, but they weren't going to get paid for it. Behavioral health parity was another gap. People said that even where people had health insurance, oftentimes the health insurance didn't include access to behavioral health services. There wasn't a behavioral health component to that. And again, the rates of reimbursement for services weren't comparable to what you might see with other kinds of physical health care. We knew that there was a gap in workforce. What we heard from children, what we heard from parents is that some of the behavioral health services that they want more access to is individual counseling, group counseling, as examples. And even though we talk about the behavioral health workforce being very broad, there is a small group of behavioral health professionals that are actually licensed and able to provide counseling services. That group of behavioral health professionals shrinks. And so, of course, workforce is a major issue. Behavioral health data and healthcare information and technology. Texas A&M University, and I don't think I'm speaking out of school about this, this was a study led by Dr. Marcia Ori and Dr. Israel Lieberzon. What they said is that in their conducting this study on what the inpatient needs of children are, they had a very hard time of finding data that tracks episodes of care of children. Even if you're looking within one organization, multiple programs within that organization, they couldn't find data to show that a child served in, say, behavioral health services who's also receiving juvenile justice services. They didn't have a line of sight on what care they were receiving between systems. And then what we heard is that there is a need for more crisis services, things like youth crisis outreach teams or mobile crisis outreach teams. We heard that there's a need for more outpatient services, particularly things like some folks have talked about coordinated specialty care for first episode psychosis, multi-systemic therapy, functional family therapy. There were several different kinds of evidence-based practices that kept coming up in the conversation. Residential care. Again, going back to the acuity piece, people said, you know, we've got crisis respites, we've got crisis residential units, we've got some of these other kinds of facilities, but even these kinds of facilities aren't really primed or even structured environmentally to be able to serve the kinds of kids that we're talking about here. And then, of course, inpatient care was also identified as another level of need. So we were tasked, right, with coming up with what do we think this continuum of care of children should look like. And so the figure that you see on your screen is what that looks like. So where you see service delivery system supports, that's where we're talking about things like rates of reimbursement for behavioral health services, building out your behavioral health workforce, making sure that there is parity in terms of behavioral health, insurance coverage for behavioral health services and payment of those services, and the enforcement of parity laws. Because those things really undergird how services are provided, right? You can give me all the money in the world. If I don't have providers to deliver it, I don't have a setting for people to go to, it means nothing. The next level up is behavioral health awareness. What we heard, especially from children, which I was shocked by this, I don't know why I was shocked by this, but in our focus groups, what we heard from the children is that there's still lots of stigma around talking about mental health and substance use concerns, particularly in academic settings. They said, yes, in some instances we have a counselor available, but we really worry about seeking care from a counselor and if that information might make it to, our friends at school. And so there's still stigma there. So there's a need to break down that stigma. We think prevention and early intervention care is important. You can prevent the onset or maybe lessen the acuity of behavioral health conditions if you can identify people early. So really investing in more upstream services. Outpatient care, again, people said we want individual counseling, we want more family therapy, we want more evidence-based intensive services that we know are gonna be cost effective and produce better health outcomes. Residential care, we heard from people that we need more things like crisis respite facilities. People have talked about a need for psychiatric residential treatment facilities. People have talked all different kinds of facilities, y'all. I've learned so much. And then inpatient care, that there is a need for beds. And they said for each of these levels of care, we need a system that is flexible, where you can step people up as needed, but you can step them down as needed as well. So this plan is going to go live December 1st. There are 31 recommendations in the plan, 31 recommendations, but I think all of them do have merit. And so if you're interested in reviewing the plan, please take a look at it. HHSC, the Health and Human Services Commission, actually has a placeholder exceptional item for the plan. So if any of you all are policy wonks or fiscal wonks and you've looked at our legislative appropriations request and you see something that is labeled Children's Mental Health or Children's Behavioral Health Strategic Plan, it is so that the agency left ourselves some flexibility to look at this plan and identify which recommendations we want to go to the legislature and request funding for. So we have been engaged with the governor's office and other legislative offices on these matters since the summer. So any questions? I don't know if we have time for questions. Probably not. Okay. Okay. Any questions? Okay, Anna. Hi, Anna. Okay. Maybe just one.
So first, thanks. I have a little awareness of how much work went into this, so I really appreciate all the work that everyone involved did on creating the plan. One thing that I am concerned about is addressing the systems the kids are in. Yeah. Given some of the presentations that we've had so far, even here, about transgenerational trauma, the lack of intervention, especially for adults who have experienced that. So we have hurt adults parenting. Yeah. And so I'm wondering, and I know I've supposedly reviewed everything on it. I did not read every word. Is there anything in the plan to look at support for families, the family systems, those non-medical drivers of family health and community health that impact these kids?
Probably not to the degree that people will want to see, right? These non-medical drivers of health, things like housing, things like employment, things like childcare, right? I mean, I'm not trying to put my business out on the street, but I tell people with my twins, my childcare is $2,000 a month. Now, even if you have a hearty salary, I will just tell you that it pains me
Yes.
to make that payment every month, higher than my mortgage. And so you won't find those kinds of recommendations in this plan, but I will say this. Another initiative that the Texas Health and Human Services Commission has been working on is a family health services roadmap. And in that roadmap is where you will find those kinds of recommendations. So we try to work very closely with our Family Health Services Department to be sure that both this behavioral health strategic plan and the family health roadmap were in alignment with one another.
Okay. Thank you.
Okay, I don't think we have time for any more questions, but thank you all so very much.
My cheat sheet here on my iPad. Well, good morning, Brian Shannon. If you heard from Judge Specia, I teach at the School of Law, and I got to first start by, I guess, apologizing to the judges in the room for not wearing a tie. But Christy and her staff sent out directions to the male speakers, don't wear ties. I feel like I've been punked. So, Your Honors, sorry about that. I was telling my wife last night about all the great presentations and about how, for example, Judge Jones and Vicki Rice had included in their great presentation both music and dancing. And she strongly discouraged me from trying to dance. So I thought, well, maybe instead I'll have a couple of dad jokes. So you've probably heard this one, but remember the old light bulb jokes? How many psychologists does it take to change a light bulb? Well, just one, but the light bulb has to want to change. Yeah, need a little rim shot. One you probably haven't heard, though, is how many law professors does it take to change a light bulb? 0, because most law professors want to keep their students in the dark. So... All right. So we're going to talk some about the efforts by the Judicial Commission to propose legislative changes to try and improve the legal rules, the statutes that relate to the folks whom many of you serve and that we're all familiar with. This is we're going into our third session of having a series of proposals coming from the JCMH. We probably had a little better track record the first go-round. We got some things passed last session, not all. A few of the proposals I'll talk about might seem familiar because we're going to try again. As many of you who've worked with the legislature know, it's much harder to pass a bill than to kill a bill. It takes compromise. It takes a lot of work. What I want to highlight for you in a little bit are proposals that we have going forward in both the criminal space as well as the civil space. And you heard from Christy yesterday that we have 16 different concepts or proposals that we're going forward. Now, that doesn't tell the whole story about the committee and the commission's work. We probably started with closer to 50 ideas for different kinds of legislative approaches, narrowed that down, and then moved forward with bill drafts on about 20. And then some of those didn't pass muster with the required 2/3 vote within our full legislative committee. And then a few were tweaked by the executive committee for the Judicial Commission as well. So I think you can feel good as participants and those involved in the process that we've given these a serious look as we've gone forward. There were some other concepts and ideas that probably aren't ready for prime time that we'll go back and work on perhaps prior to the next session. So let me jump into them. And, well, I clearly am not adept at some of the PowerPoint. Just because tech is in my employer's name, maybe I don't have special skills in that area. This looked really good when I sent it. Where there are words and then pictures down at the bottom. Is there a way to switch this so it's actually in the presentation approach? I think it's toggled wrong, but oh, now we've got some mood lighting as well. Talk about the law professor leaving you in the dark. So I think they're going to try and play with the PowerPoint just a little bit. So let me go to my trusty thing, and we'll just use words here. Bear with us. All right, in the criminal space, the first of the proposals that we've had in the criminal space is to pick up on some that we've been talking about, clarifying that AOT courts count as specialty courts. There's specialty courts legislation that's existed for several years now, several sessions. Ah, beautiful. Thank you. So it wasn't entirely my fault. So one thing that was brought to us by Daniela Chisholm and our friends in El Paso that we worked through was some clarification that the specialty court statute didn't recognize AOT courts. That can be important for seeking grant funding for the creation of these courts, as well as some other reasons. And so this bill would simply do that, to be able to identify those. Similarly, when talking about AOT courts, Judge Carr brought to us an issue that we worked through and came up with some legislation assuring that judges who are overseeing specialty court programs, such as mental health courts and AOT courts, among others, that they actually have jurisdiction over both, in effect, misdemeanor level offenses and felony level. So often we'll see referrals of cases involving persons with mental illness to a mental health court coming from both the felony level district courts, in effect, as well as court at law, and making sure that a court at law judge does have statutory authority to be able to preside with respect to those cases. Often this is taken care of through local administrative rule, but that can sometimes be cumbersome. This would just set this as a state standard. Now, after the matter has been processed and somebody successfully goes through the program or doesn't successfully go through the program, the court that has jurisdiction over the program, is supervising the program, would still be referring that person back, transferring the person back to the disposition court for decision. So this is not about taking away any dispositional authority on the part of, say, a district court if within a county, the court at law judge is running the AOT, specialty court program. Pam Liston helped lead the effort on this. Article 1623, passed several sessions ago, was something that came out of and was a piece of the Sandra Bland legislation, which has the aspirational goal and requirement that all local law enforcement authorities are to have mental health diversion plans in place. A couple of challenges with that statute was it talked about, or currently talks about, requiring that those plans have persons diverted to a place, to a facility. And in some of our rural counties, that's not an option. There may not be a place or facility. And so this legislation would change that to talk about, in effect, a place or a program, a facility or a program, and doesn't limit it to the jurisdiction of the county, because some of our counties don't have that opportunity, but an adjacent county will. And so that would permit greater flexibility in that space. In addition, there's a reporting requirement to send in information about the plans to a centralized agency so that good ideas can be shared and that would be available. Now, switching to the criminal side, and some of these, as we talk through, there's some overlap between criminal and civil, but let's talk about the criminal side. First one there identified as D is taking a look at jail-based competency restoration and considering the ability or giving flexibility to counties to expand offenses that are eligible. When 46B-091 passed several sessions ago to specifically authorize jail-based competency restoration programs, they were limited in their scope of the people whom they could serve to folks who were not charged with any type of violent offense, the old 3G type offenses that still are present in other places, like in 17032 of the statutes. Well, then we've got this perhaps challenging setting where somebody could be charged with such an offense, could have been adjudicated incompetent to stand trial, and yet they might have to wait a year or more for placement in a maximum security unit. And so this statute would make it permissive, if the program opts to do so, to allow somebody charged with that violent offense to receive JBCR services there in the local jail. And the view is, well, my goodness, jail's a pretty secure place, right? And yet we're going to have them sitting there as under current law in the jail for perhaps a year or more before we can transfer them for competency restoration services, where they might not be receiving services at all during that period of time. So this would create that option if it's enacted. I should add, too, the full proposals are available in the materials. It's about a 52-page read. So if you need some help getting to sleep tonight after you get home, you can read through some dense legislative proposals. The next segment, look at some changes to Chapter 46B, the Competency Restoration Statute. The first is one that we tried last session, and we want to try again. A number of jurisdictions now don't require competency restoration if a person is incompetent and charged only with a misdemeanor. They've taken that approach that community-based mental health services often are a better option, or outpatient competency restoration or jail-based competency restoration. This would address, in Texas, we're not saying all misdemeanors, but in our proposal, in effect, non-bodily injury misdemeanors. So Class Bs and those Class As that did not involve some type of bodily injury or threat of bodily injury, or somebody who's had a history of bodily injury offenses. And Judge Farmer helped with the drafting of that aspect. So it would require for those sorts of offenses to default to outpatient competency restoration, and absent the availability of outpatient competency restoration would require, in effect, a conversion of the process, a referral over to outpatient civil commitment. So it would be a policy change, but recognizing that with people who are only facing misdemeanors, who are found incompetent to stand trial, and at least the history of wait lists, they time out without getting services. Class Bs, we're talking about 180 days, so 6 months, they may time out. With Class As, it's a year. So they may have timed out before they ever receive competency restoration services if they're ordered to inpatient, or even if they get to a bed, they time out before the state hospitals had many days to have a chance to restore the individual. The second bullet there is trying to refine some of the statutory language around, well, basically clarifying some terminology. The statute, as many of you know, has repeated use of the phrase foreseeable future. And that's an important phrase that if somebody's not going to be restored within the foreseeable future, we end up with a different set of processes. How many of you could stand up right now and give me a good idea of what foreseeable future means? How many of you who are forensic psychologists, forensic psychiatrists have a good feeling for that? I can tell you foreseeable future, I think my wife expects me to cook dinner tonight. Beyond that, I don't know if I've got a lot to tell you in that space. So what we're trying to do with that is have a functional definition, because what it really means under the statute, and Chris Lopez came up with this language, is it means we're talking about, do you, doctor, believe that this person can be restored within the time periods authorized by the statute or not? Seems like a much more direct way to think about. We also are going to include, or have included, we tried this last session, I don't think it's controversial. Prosecutors, defense attorneys, and judges have all clamored for what's identified as 3 there. We have a recurring problem where somebody who's been restored at the state hospital comes back, and for whatever reason, whether the case doesn't get called right away, they stop taking their meds, what have you, the person decompensates and is no longer competent yet again. 46B-084 just doesn't have much to address that. And so this provides some statutory language to give courts, prosecutors, defense attorneys a guidepost of what to do, what steps to take. The 4th bullet there, a few sessions ago, we passed legislation that if somebody is not capable of being restored and is on a long-term state hospital placement, we added a step-down mechanism to permit the possibility for appropriate persons to outpatient. There's not a parallel currently under the law for somebody with an IDD diagnosis. So this statute, if enacted, would permit the possibility of a step-down from a state facility to a community-based type treatment plan. It's not really outpatient, but for shorthand, that's the parallel that we're talking about. So to be able to have that flexibility and be able, in appropriate cases, at least have that option to move somebody out of a state-supported living center who has been found not restorable. A couple more criminal ideas. We hope the 3rd time is going to be the charm on F. We've had variations on proposals in each of the last 2 sessions when we're talking about Class Cs. So in our justice courts and municipal courts, constitutionally, we can't lawfully adjudicate somebody who's not competent. But 46B, all of the competency process, competency proceedings only apply to persons charged with Class Bs and up, because there has to be that jail aspect, and that's how 46B is written. This would amend Chapter 45A to permit a possible dismissal of the misdemeanor if the person appears to the court to lack capacity. This time, our proposal mirrors exactly language that's already in Penal Code 8.08 for juveniles. And so we're hoping that this one will get traction at this point. The next was brought to us by Judge Phillips and others who have constant challenges with respect to court-ordered medication proceedings under Chapter 574 of the Health and Safety Code, as well as 46B-086, in having sufficient numbers or availability of physicians who can raise the claims and testify in the particular cases. So this would expand and authorize often the persons who's providing the direct services. For example, an advanced practice psychiatric nurse or physician's assistant to be able to testify in such cases. Let me switch to the civil side then. One of the proposals would modify the peace officer's emergency detention form to better elicit necessary and helpful information. Elise Ferguson worked on this, took the lead. Chief Lee from Harris County assisted, as well as other law enforcement. As you know, many sessions ago, because of peace officers being presented with a wide array of forms in civil emergency detentions, every hospital seemed to have their own form. No, that's not going to work. You got to use our form. We love our form. Our lawyers wrote our form. Chief Lee came up with the concept, and law enforcement helped push through legislation to create a statutory form. Great change. Certainly members of our committee are strongly supportive of that. There are some ways to improve it, though, and what this proposal does is add some blanks to be able to provide some additional reasons, lay out the specific statutory standards that are there, have some check boxes. Some of these had been used for some time as a supplemental form in Collin County that the officers are also trained on. One of our goals, though, in doing this was to still keep the form at 2 pages and not exceed that. So we think these would be very positive sorts of improvements there as well. B picks up on some legislation that was enacted last session. Last session, well, let me back up. A constant concern and problem that we hear from law enforcement is that they will take somebody to a facility on an emergency detention and then have to sit there for sometimes hours while insurance might be being checked, the person's being screened for other medical issues or what have you. We'd like our officers to be back on the streets doing what we want them to do and what they've been hired to do. The legislation that passed last session relates to if the officer is serving a magistrate's warrant, then once they present the person, fill out the necessary paperwork, they can be back off and on their way doing what we want them to do. This would create parallel language when we're talking about emergency detentions that are the officers bring the person in absent a warrant. So once the person's presented and the paperwork's filled out, that 2-page form I was just talking about is presented, the officer would not have to continue to stay. That's certainly been the goal of many of our crisis drop-off centers. This would create some consistency in that approach. C is clarifying proper venue for a civil commitment. And in this fun Friday morning, and you're all sitting around, we're going to talk about venue in civil commitments. But it's become a problem, become an issue, because the statute talks about right now the civil commitment proceedings should take place in a court where the person with mental illness is found. Well, I don't know, what does "is found" mean? That sounds pretty good. He's there. We've found him. But think about some of our counties that have boundaries. Oh, all of them. And think about sometimes where the facility might be on the other side of the county line. Think about the Metroplex with multiple counties intersecting, and you might have a lot of individuals who are seen at Parkland Hospital, or up in Amarillo where there's 2 main counties adjacent to each other, or out where we are in Lubbock where our Sunrise Canyon Hospital is in Lubbock County, but we serve individuals from counties that surround it. So this has come up as a recurring issue of, well, where should the civil commitment be heard? Which county? Where the person was initially apprehended or where they're receiving services? We came up with, I think, a pretty good fix. I hope the legislature agrees. How about either? So the language we've used is where the person is located at the time the application is filed, which is usually where the facility might be, or where they were apprehended. That either could be appropriate. And then D, trying to address the common symptoms of anosognosia, trying to address that issue. We heard from Dr. Amador a year ago. How many of you were here for that or online for that? So quite a few. As he talked about one of the very common symptoms, particularly of schizophrenia and bipolar, sometimes up to some studies like 50% of the people with those illnesses have this condition of anosognosia, an inability to recognize anything's wrong. How many of you have ever worked with an individual with schizophrenia or bipolar who does not recognize anything's wrong? And I certainly remember that from my own brother's illness as well. Well, if that's present and their condition is deteriorating, isn't that something that we ought to take into account when we're looking at this? So some states, notably Michigan and Arizona, among others, have changed their civil commitment statutes to, in effect, recognize this as being a common symptom, to include as one of the criteria or possible criteria for an inpatient civil commitment when an individual lacks the capacity to recognize that the person is experiencing symptoms of a serious mental illness and therefore isn't able to make a rational and informed decision regarding their treatment or appreciate the risks or benefits of treatment, to be able to understand, use, weigh, or retain information relevant to that, and in the absence of treatment is likely to experience a relapse or deterioration that would meet some of the other criteria, dangerousness, for example, or substantial mental or physical deterioration. So this would add an additional prong to the current criteria for inpatient civil commitment. It is not too dissimilar from what we have in the criteria for outpatient commitment. This language, largely drawn from these other state statutes, was also consistent with a national task group that I had the privilege of serving on that was making recommendations for some uniform type statutory changes. The statute would also include some slight verbiage changes when we're talking about, for example, in the emergency detention space, when an officer has the, in effect, ability to intervene where the officer has probable cause to believe the person is a person with mental illness and is presenting a danger to self or others, or is evidencing severe emotional distress and deterioration in their condition. Evidencing severe emotional distress and deterioration in their condition, we propose adding language that would say, which may include an inability of the person to recognize symptoms or appreciate the risks and benefits of treatment. How many times have you seen family members who've implored their loved one, can we take you to the hospital? Can we take you to go see the doctor? There's nothing wrong with me. There's something wrong with you. And sometimes that might be true, but more often we're looking at somebody who is, because of the symptoms of the illness, unable to appreciate the challenges and risks that are present. So that's a quick walkthrough among the various provisions. The entire document not only is in your conference materials online, but also linked on the JCMH website. And I think there's about 5 minutes left, 6 minutes left. Sure.
Does anyone have any questions?
Thank you so much, Professor Shannon, for your work on this and the committee as well. As a former criminal defense lawyer that was kind of the designated mental health attorney in Williamson County before I went back to work for the state, the legislative proposal dealing with adding categories of assaultive crimes in regards to some of the programs that we've been unable to do that in the past, does that include offenses of a person incarcerated in a jail that assaults one of the jail staff, or in a hospital where they assault maybe one of the staff members at the hospital? How are we dealing with that? Did that look at that, or is that outside the scope of what y'all looked at as far as these people being able to be considered for programs? Because those assaults typically occurred because they were off their medication at the time.
Yeah, we had proposals each of the last couple of sessions that did not get traction in the legislature to to basically address the kind of thing you're doing. And I hope we revisit that. It's not a part of our proposals this time, but so somebody is brought in on, if I think I understand the question, say they're brought in on emergency detention because they may be dangerous to self or others, or their condition is deteriorating. And while in the emergency room or while at the mental health facility, they strike a nurse or they strike the officer. And then we have almost a reverse diversion, if you will. They're taken to jail as opposed to others. We've had some attempts at trying to get some legislation to say, law enforcement, the county still has that ability to consider the criminal aspects, but we were trying to put a stay on it, to defer that until a later date to try and get them some immediate treatment. And that's not part of the proposal this time, but we have tried that. And I'd like, if you've got ideas for coming up with another way to do it, we'll try again, because I think it's going to take some close work with the Hospital Association and others to successfully push something through.
Well, thank you, and maybe
Sure.
we can visit that at a later date. I appreciate
You
it.
bet. And anybody who might want to serve on the Legislative Committee in the future, there's a seat at the table for you.
This is our last question.
Okay, Judge Peace, Associate Commissioner Harvey, and Professor Shannon, thank you for what you're doing. Mike Taylor from Tropical, Texas. Just wanted to ask for consideration in the modification on the transfer of custody issue that we're working on for the 573-001 released by an officer when they initiated the detention. Critically important to clarify or make sure it's clear to all law enforcement and other partners that facility, the definition of facility in that statement is critical, that if it is just somebody being released to an emergency room only that has no provision to retain or take the transfer of custody of that individual, then that individual is released essentially out into the community. They can walk out of that emergency room. Oftentimes it's in a urgent care facility. And if the officer releases that person without being able to transfer custody to a licensed peace officer in that facility, and it's not an inpatient mental health facility as defined in 571, we're having some unintended consequences. Is that making sense?
I think I follow the question. We've seen some counties where the county judge or the judge with probate jurisdiction for the county has specified specific facilities or identified all, and maybe that's a non-legislative approach that could be
Well,
taken.
under 573, the guidance is that the individual taken into custody is transported immediately to an inpatient mental health facility, and there is a definition of facility in that context in 571. And it also allows for other appropriate facility or other facility as deemed suitable by the local mental health authority. So it's just important to make sure that we're clear with our officers that custody is being released either to a place that can secure the individual or to another licensed peace officer that can maintain that custody until the individual does have access to the secured facility. Otherwise, we have elopements out back into the community and they're on the streets.
Yeah, thank
I'm
you.
going to ask y'all to take that offline and have that discussion so we can keep going.
Okay, well, thank you very much.